Hello everyone, can you hear me? I think we'll start kicking things off, but just let me know in the chat if you can hear me. Okay, fantastic. Good, great, great, great. It's nice to see so many of you here on a Saturday morning. I know that people have just recently applied for their PACES exam dates, and you're probably going to hear soon. This is probably a nice time to really start knuckling down on your revision. For those of you that don't know me, my name is Shuaib. I'm the course organizer for BitePACES, and as you know, we're going to be doing a webinar on cardiology today. And just before we kick off, and I hand over to Chern. I am just going to quickly do a run through on our course. Um, and we have our courses coming up in May and June, which you can check out on our website. I'll post the link in the chat, but also you can use the QR code at the top right there. So we have a 1 day course and a 3 day course. We've actually recently changed things around. We used to have a 4 day course, but we thought that actually a 3 day course is more affordable and you can kind of do as much in a 3 day course that you can in a 4 day course. So please do check out our offerings. I think what we really pride ourselves on is small group teaching. So there's never more than two people at the bedside. We have some really nice cases, across all the different types of stations. We cover clinical consultations. And we have some really great tutors, one of which is Chern, who actually teaches on our course. Um, if you use the discount code, you can get £20 off. And also, please do sign up to our WhatsApp group because we'll be releasing more webinars soon. So you can sign up to that at the bottom right there with that QR code. And just so you don't take my word for it, we've got some really great feedback. We've got kind of 50 reviews on Google, almost 5 out of 5. So yeah, please do join us. It'll be great to see some of you in person. We're based in London at Guy's Hospital. And sadly, this is the last webinar of our current series. But as I said, we will be releasing more webinars in the future. So please do join our WhatsApp group. And for most of our previous webinars, they are uploaded on YouTube on our BitePaces YouTube channel. So you're more than welcome to head over there and watch the recordings. But without further ado, Chern, I can see you're ready to go. Is it okay if I hand over to you and I'll stop sharing my screen? Perfect. So I'm going to disappear into the background. And yes, Chern is a cardiology registrar. He's one of our faculty members, teaches on the in-person course, and has done a few of these webinars, and I'm sure you'll find this very beneficial.
Hello. My name is Chern. I'm one of the cardiology registrars at Princess Royal Hospital in Telford. I think my, hang on a second. Am I muted?
No, that's perfect. We can hear you, Chern. I can see your slides.
Oh, okay.
They're
Right.
not
Okay.
they're not in the I think you need to, put them in the full screen mode. Yeah, there you go.
There we go. Right. So restart. My name is Chern. I'm one of the cardiology registrars at Princess Royal Hospital in Telford. So what I will be doing today is to give you a guide into your cardiology station. Now, what I'm not going to do today is to give you the explain the entire cardiology textbook of all the different sort of cases that may or may not show up in in your cardiology station because that's too broad. I'll focus on the main ones that could come up. But more importantly, I'm going to give you a comprehensive run through of how you should perform your cardiovascular examination and what you should be looking out for when you look at someone's chest, when you see a patient at the end of the bed, what you should listen to, so that that can start get in your noggin running. Okay, it makes you think as to how am I going to piece all of these findings together to come up with a comprehensive list of differentials and a management plan for the patient. I think it's quite useful for me to have now attended a couple of couple of teaching sessions face to face, and that's gonna hopefully make this a little this explanation a little bit better as well. Just to discuss the quick patient station format, your cardiovascular station will be 10 minutes long. You have 6 minutes to perform a cardiovascular examination, which in my experience is very easy to do. It's very easy to go through a cardiovascular examination in 6 minutes without having to listen to the chest in 12 different places. So that's pretty useful. But it's also daunting because there are some murmurs where it might trip you up. So today, hopefully, I'll be able to give you some tips as to how we can increase your confidence in listening to some murmurs in terms of knowing how to elicit them and how to describe them, and amongst other stuff as well. And then you need to use your 4 minutes wisely to present your case. And that's very important. You have to keep things very short because 4 minutes isn't long to go through differentials, and the management plan, and also your list of investigations. Most important thing, always treat the patient respectfully and sensitively, and always maintain their comfort, their safety, and their dignity. Don't expose them unnecessarily. Okay? So yeah, an example of a written instruction, you have this 70-year-old man has chest pain on exertion. Please examine his cardiovascular system. And then the clock will start. So in terms of approaching the patient, is there anyone in the chat that wants to sort of tell us how you want to approach the patient when you first come in, once you've read the scenario? Oh, yep, go for it. Is anybody? No, that's fine. Don't think I can see anybody's messages so far. Oh, if you just write it. Oh, I can unmute. Oh, there we go. Right. Do you wanna, or just write, you know what? Just, yeah, introduce the examination, take consent. Perfect.
Okay.
Keep it nice and short. Introduce the.
Okay, can I do it?
Yeah, go for it.
Okay. Yeah. Hi, my name is Dr. Sana. I'm one of the doctors in the clinic today. Thank you for letting me examine you. Let me know if I cause you any pain or discomfort. I'll stop my examination.
Okay, sounds good. Yeah, that's very nice. You could probably also add things, just a quick one, just to add, I will be examining just like a medical student OSCE exam. I want to examine from your arms, your face, feel for your pulses, and have a listen to your chest. Okay, and always reassure them as well. Okay, so that's good. Always introduce the patient and introduce the exam. What you then also want to do is, just after you're doing that, is to stand at the end of the bed. Okay, because this is where you want to see how the patient looks like. Are they comfortable? Are they in pain? Are they cyanotic? Okay. You also want to see that whether they have any medications on their bedside. Okay. Now, I've put these pictures just for intent purposes, because when I did my paces, it was during COVID time, so we had to wash our hands and wear your gloves. So if there's any there, obviously do that as well. We put, introductions, ask them for their permission, and expose them appropriately. All right. Bedside exam. Okay. Like what we discussed, pain, cyanosis, any chest deformities. Okay. In terms of deformities, you're going to look for pectus excavatum, carinatum. Okay. Do they have any facial abnormalities or structural abnormalities that make you think, oh, is this a genetic? Could this be more genetical? Okay. You look for scars. So, can I have it in the chat as to what scars you may want to look for? Throw in a few scars. Yep. Median sternotomy scar. Yep. Good. Anything else? Any other scars? Okay. Yep. Yep. If they recently had chest drains. Abdominal, maybe not so much in a cardiovascular exam. Yeah, very good. Yep. Left infraclavicular scar. What? Graft sites. Yep, good. Where can you look for graft sites? Yep, pacemaker scars. Yep, that's where your left infraclavicular. Yep, saphenous vein. Yep, very good. Okay, so pacemaker scars. Having implanted a few myself now, just remember you may not only find it in the left infraclavicular region. Where else can you find a site where you think a pacemaker might be seated? Might be implanted, sorry, not seated. Where else can you find a pacemaker? Right infraclavicular, very good. One more place. There's one more place where you can find. So you got your left, you got your right. Abdomen, absolutely abdominal. Okay, three sites where you can put pacemakers. ICDs, again, typically left infraclavicular. Where else can you find an ICD? So if it's not transvenous, where else can you implant a pacemaker? Sorry, an ICD. Same site as some of your drains. Okay, no, that's fine. So for ICDs, traditionally transvenous implantation, always check mid-axillary because you will see more and more people, typically younger patients, with subcutaneous ICDs, okay, where you're going to have your ICD implanted in the left mid-axillary region. All right, good. Obviously, listen at the end of the bed as well, because if you hear that if you hear that metallic valve, you've got a metallic valve there. That's part of the job done already. Okay, that's a great hint. Obviously, bedside, look at medications. Do they have sprays? Any medications that might point you towards a particular disease if you're stuck? Any ECGs if they're available. Good. I like this YouTube video for prosthetic valves. If I can people hear that? No? Can you not? Oh no. No. No, can't see nor hear. Okay. Nope. Okay. Right. So I apologize. It did work on Microsoft Teams the last time. But so
Chang, if you want to
Yeah.
get the sound to play, I think if you share the screen of the video or
Oh
the
yeah, sorry
that
about
that
that.
might
Yes,
work. You can give that a
that
try.
might work. Yeah. Sorry about that. I think that's silly me. Right, share screen. Oh yeah, that might work. Stupid. Ah, there we go.
No, it's still not working for some reason. Not sure.
Still not working.
Yeah, yeah.
Okay. Ah, uh, I'm literally at the loudest as well. Here an example of that. Can you hear that?
It's pretty faint, I think. Yeah, I think it's gonna be
Is
quite,
it very faint?
yeah.
Okay. Right. So I think just to go back, I think I'll drop the link because it hasn't sort of worked. What I would say is that when you come to listen to metallic valves, if the metallic click falls on S1, you know that that will be a metallic mitral valve. Okay. If there's a click at S2, it will be a metallic aortic valve. Okay. So S1, metallic mitral, S2, metallic aortic. Okay. For these patients, you're going to look for bruises as well. Good. So I will see if I can do half screen here. So can I get people to sort of drop it in the chat? So I'm going to point my cursor onto the screen. What's that one here? Sort of in terms of looking for signs with the nails.
I think we're still looking at the YouTube screen,
Oh,
Jen.
you're looking at a
I
YouTube
think we
screen.
need to reshare the
Sorry,
camera.
guys. Better now. Better now.
Yeah, perfect. Just full screen. Yeah,
Perfect.
you can see the screen.
Yeah. Doo-doo-doo. Right. So drop it in the chat. Oh, there we go. Oh. Right. So drop it in chat. What can we see with that first nail? I can't see people's response here. Yep, clubbing. Yep, very good. Right, number two. What's the second one? What's this one? This one here. Yeah, hyperhidrosis. Yep, that's very good. So if you've got a patient like this and they're very slim, they're tremulous, if they have an irregular pulse and maybe some, if you look for, a goit, a neck lump, what could they have? If you just piece all of that together. Hypothyroidism. Yep, very good. Thyrotoxicosis. Perfect. Right. How about this one here? Yep, that's cyanosis. Yep, very good. This one. Where my cursor is pointing, if my cursor shows up. Tar stain. Yeah, I would say maybe more splinter hemorrhages. So tar stain you tend to have like a more like a brownish hue Whereas splinter hemorrhages, they look like splinters. So you can see on the nails, they have more like straight line, whereas with tar stains, they tend to have like a large horizontal band just underneath the whites of the nails, and the whole nail can look quite yellow as well. Okay, more than one splinter hemorrhage, splinter hemorrhage is more than one finger increase in one nail increases your suspicion that whether this could be infective endocarditis. This one over here. What have we got in this bottom right image? We're not at the nail now. Yeah. Okay. What makes you think that they are intravenous drug users, Anna? What are these? What are these scars? Yeah, needle stick marks. Fantastic. Okay. Osler and Janeway lesions. What condition do they tend to appear in? What are they pathognomonic for? Osler and Janeway lesions. Infective endocarditis. Fantastic. Which one is painful? Which one is painful according to the textbooks? Osselers. Yep. Osselers. Ouch. They are painful. Okay. Now, to be frank, never seen one of them before in any of my patients with infective endocarditis. Okay. And then just looking at these last two pictures, we got the cyanosis here, and this tends to be more of your tar staining here. Okay. Right. Next one. Good. So pulses, obviously regular, irregular. You look at your rate and you look at your character. Are they a collapsing pulse, slow rising pulse, water hammer pulse? Okay. And then you then want to tell the examiner that you're looking for the brachial pulse and also the blood pressure as well. Traditionally, they'll tell you to continue moving on at this point. Right, another visual cue. So let's have chat do the work for me. Right, top left. What do we have? Malar, absolutely. Malar for MS, very good. What do we have in this picture here? Right in the middle, top middle. Amiodarone, why? Why is it an amiodarone toxicity? How would you describe this appearance? Yeah, slate gray. Okay, slate gray appearance. How about this one here? What does this gentleman have? Top right. Downs, perfect. What conditions are down? What sort of cardiac conditions are Downs patients susceptible to? What cardiac conditions? ASDs? Anything else? VSDs, yep. So it's all your VSDs, ASDs, AVSDs. Yeah. So always look out for the murmurs. Good. Bottom left. Stretchy skin, is it Marfan's? EDS, yes. EDS, Ehlers-Danlos. Fantastic. So if at the end of the bed, they look like they've got stretchy skin, hyperextended, fingers that are hyper flexible, what other things that you want to look out for in terms of your cardiac examination? What other sort of cardiac manifestations or Ehlers-Danlos would you want to look out for? Yep, AR. Yep, MVPs. POTS, perfect. Absolutely. Definitely look for that mitral valve, look for that prolapsing murmur, look for aortic regurg, especially if you're concerned that this patient may have an aortic dissection. All right, good. Bottom middle. Thyrotoxicosis, perfect. Graves. Last one here, bottom. This one here. Yeah, bottom right is dental Just before that, yeah, corneal arcus. Yeah, anemia, perfect, good. Definitely anemic. Right, next one. Okay, so for your neck, check whether they have a raised JVP or a normal JVP or an absent JVP. Okay, if they have a raised JVP but it's not pulsatile, you're worried about SVC obstruction, tends to maybe come up in your respiratory exam rather than cardiac. Absent A waves, you're looking at AF, absent JVP, maybe because they are dehydrated as well. If you can see a large V wave, you're thinking, do they have right heart failure? Do they have severe tricuspid regurg? Okay. Always do your hepatojugular reflex if you cannot see that raised JVP. All right, just to see whether you can elicit a JVP waveform. Okay. Good. Mouth. Another one for you guys. And where is chat? Good. Yeah, so what do you mean when you're seeing a V wave? So V wave, ventricular contraction. When ventricular contraction in the when your tricuspid valve is closed, when you get a large tricuspid regurg, okay, a lot of the blood that should have been emptied during ventricular contraction, okay, basically shoots back up, all right, into the right atrium, bounces back into your JVP, and you will see a large JVP waveform. Is that okay? Good. Right, let's look at the mouth. So first one, I'm not gonna get you guys to say anything. Nice, pristine, they've brushed their teeth. All right. Can we identify different types of waves clinically? No. Those JVP waveforms that you see are measured and seen when you do a right heart cath. So it's more when you do your physiological examination. I think from a clinical examination point of view, it's quite difficult. As long as you mention whether they've got a raised JVP or not, that will more than suffice. Okay. Now, let's look at teeth. So why does teeth or dental hygiene in particular matter in just, from a cardiac health in general, infective endocarditis, exactly. So, yeah, poor dentition can cause infective endocarditis. You get all your strep mites infections. Really big problem because we've had a patient sort of few weeks ago that had to have all her teeth removed because her teeth were that bad just so she can have her TAVI. So that's one. Always look for teeth. Top right, what does she have? What do her lips look? Cyanotic. Bottom. That bottom picture here. Stomatitis. Very good. Okay. Angular stomatitis. Okay. Always look for, might indicate the patient's anemic, which is very good. Right, chest. Gonna get you guys to do the work again. Right. So, first one, don't need to mention, median sternotomy scar. Okay. When you see a median sternotomy scar, what sort of things might pop up in your head? You know, what sort of procedures would they have had done? Yep, cabbage. Anything else? Yep, valve replacements. Exactly. Okay, those are your two main things. All right. Sometimes not in my experience, you rarely get heart transplant patient. Yeah, you rarely get heart transplant patients or ACHD patients in the exam because they are quite tricky. Um, but never say never. Okay. Heart transplant, you probably don't want to start looking for, other manifestations of transplant related diseases. Um, right. Middle, top middle. Was it top? Yeah, top middle. What can you see? Yep, pacemakers, very good. Now, we talked about subcutaneous ICDs. That's where subcutaneous ICD is implanted, okay? Left mid-axillary. So if they don't, so these will tend to be found in younger patients, okay? Because, you know, it saves them from having a transvenous approach, and also from a cosmetic point of view as well, it looks nicer tucked away in the side. Bottom left. Can you differentiate between PPM and ICD? No. No, you can't. And you don't need to. You're not expected to. You could probably have a guess if, depending on the condition. So if, say, the patient has HOCM, okay, or the patient has a type, heart failure, they might ischemic cardiomyopathy. Okay, if cabbage, venous vein grafts, they actually might have an ICD. Or if you think other forms of heart failure, they might actually have a CRT instead. So, or a pacemaker, someone who's a little bit older. Right. Bottom left. Temporary pacing, no. We tend to do that femorally. That's just a uh that's just a pick. I just found a picture of PIC line. Yeah, central line. Because, just in case, a patient's on long-term antibiotics for infective endocarditis. Okay. Bottom right. Yep. Pectus excavatum associated with what condition? Marfan's. Perfect. Long arms, long limbs. All right. Good. So then we come into palpation. So you look at the left and the right of the sternum. Okay, that's where you want to palpate. Feel for the apex beat, traditionally left fifth intercostal space. If you can't feel the apex, tilt your patient to the left, all right? Or on the right if you feel that the patient might be dextrocardic, all right? You want to look for things like apex displaced, conditions that can cause apex displacement. So if they have cardiomegaly, heart failure, MR, their apex might be displaced. Okay, so you do have to then, if you can't feel for the apical beat, roll them to their left side. Okay, it might be impalpable if they have pleural effusions or dextrocardia, to which then you have to switch to the other side. Generally, okay, you want to feel for your thrills at the base of your fingers. Okay, so thrill is a palpable murmur, whereas a heave, where you then want to use your palm, all right, that's will point you towards a patient with heart failure because that left ventricle is having to pump, having to do a lot of work. That's why it produces that heave-like motion that you can feel using your palm. Okay? Yeah, forceful ventricular contraction, thrills, palpable murmurs. Right, auscultation. So when you auscultate, all right, and I've been caught out by this before and has been corrected now by one of the patients that I was paired up with on the last PACES course. So that is very useful actually. So auscultation, what you need to do is one hand on your stethoscope, one hand palpating the carotid pulse. May look clumsy, but you have to do it because you need to now describe, this will help you describe whether this is a systolic or a diastolic murmur, okay? If you feel your pulse is a systolic, if you don't feel, if the murmur happens when the pulse is not there, it's a diastolic murmur. And in your exam, they tend to give you your systolic murmur, so your AS, your MRs, okay? Or if they've got a metallic valve, all right? You want to go through the motion, aortic, pulmonary, tricuspid, mitral, or the reverse, but do it in a systematic manner. Always, you have 6 minutes. Your cardiac examination will take way less than 6 minutes. So maximize your time. What I have found is that a lot of people will finish the cardiac exam, say in 3 or 4 minutes, then they've got 2 minutes to stand there, and then you have to push them to say, okay, do you want to do anything else? And that's the time where people are starting to think, I don't really know what this murmur is. So then they go back. When you listen to your murmurs, be more careful, okay? Elicit things like your Valsalva maneuver. Get them to take a deep breath in and deep breath out and hold it, okay? You want to see, are there particular types of murmurs that increases with Valsalva? Use breathing, okay? Use breathing to help you, okay? If you think, okay, I've got a murmur here, I'm not quite sure, is this a TR? Is this an MR? So how does my breathing, I'm going to put it to you now, how does my breathing vary, cause a variation in the loudness of the murmur, or help you to differentiate the type of murmur? Yeah, so correct. Inspiration exacerbates right-sided murmurs. Expiration exacerbates left-sided murmurs. Okay, perfect, very good. Just want to answer that question, why carotid and not radial? You can do radial, but then there are patients with really poor periphery. So if you can't do if you can't feel for that radial pulse, I will go straight to carotid. Okay. You will get patients with quite poor pulses sometimes. All right, so I won't rely on that radial pulse there. Okay. Use your bell as well to listen for that mitral stenosis murmur. Okay, in the left lateral position. AR, get them to lean forward. So once you've done your forward, once you've done your breathing, get them to sit forward, take a deep breath out, okay? Breath hold on expiration and see whether you can elicit that loud murmur on expiration. All right? When you auscultate as well, always listen to the lungs. Don't just listen to the bases of the lungs, listen to the entire lung. You have the whole time. You want to see, do they just only have crackles in the bases, or do they have crackles throughout? Do they have reduced area entry indicative of a pleural effusion maybe from the mid-lung onwards, okay? And always listen for that carotid bruit, okay? Especially if you think you've heard an aortic stenosis murmur, it'll be good to have a listen to see whether it radiates to the carotids. And that will help you to explain, is this an ejection systolic murmur that you've heard in the second aortic, right aortic region that radiates to the carotids? That might point you towards a more aortic murmur, aortic stenosis, rather than, say, a mitral regurg. All right? Because on mitral regurg, you cannot hear the carotids. All right? I do have to say there are some murmurs where you can hear the murmurs, some aortic stenosis murmurs, or if they are loud, severe mitral regurg, you can hear it in different positions. And that's why listening to, carotids doing your breathing examinations will really, really help you to differentiate which murmur is most likely in that particular patient. Abdomen, right? Nothing much with the abdomen. We've talked about pacemakers just now. What can you see here in terms of the abdomen? Anyone wants to hedge a bet? Yeah, ascites. Okay. Anyone with right-sided heart failure, always look for it. Yep. Good. Legs. I'm gonna get you guys to do the work now. So legs, what can we see? So first picture, all right, chronic venous insufficiency, nice and simple. Yep, then the next one, saphenous, very good. And what's the one at the bottom? Yeah, edema, good. So, investigations. You want to, once you've done your differentials, okay, you have that 4 minutes, so have a bit of time to think, okay, before I present my case, I've got 1 minute left to spare. This is the time I'm going to start doing my differential diagnosis. Which murmur is louder? Which one is the most likely murmur? Okay. Is this an aortic stenosis? Maybe the other one's a mitral regurg. Okay. Or this is a patient with a CABG who's then had a prostate aortic valve replacement. All right. Now, the next question that they're going to ask you is, what are you going to do? How are you going to investigate this patient? Okay, so always bedside, look for observations, ECGs, arterial blood gas, particularly say if the patient is unwell and short of breath. Bloods wise, standard set of bloods. Anyone with heart failure, always, or you feel like they're anemic, please do TFTs and iron. And that's for real life situations as well, because thyrotoxicosis, hypothyroidism can worsen heart failure, and iron will certainly make the symptoms of shortness of breath worse in patients with heart failure. All right. Imaging wise, obviously, depending on the patient, x-rays, if you feel like they're overloaded, definitely get an echocardiogram as well. Is there a chance that AS murmur can be heard in the left axilla? No. No. I think it is very unlikely. But I have to say, I have heard MR murmurs in other regions of the chest, which is why it's really important to do your breathing examinations, all right, and take that time. Because you can easily hear an MR murmur in the aortic region as well. It's not that far away, all right? But AS murmur in the left axilla, very unlikely. MR to carotid. What do people think? MR to carotid. What do people think? Can you hear, or has anybody heard an MR murmur to the carotid? No, exactly. Yeah. So to answer your question, no, the MR doesn't radiate to the carotid, which is why listening to the carotid pulse is quite important, auscultating for your carotids, because if you heard a murmur, you're not quite, say you're nervous, all right? You didn't do so well in the previous station, you're trying to save, starting to affect this one. Just take your time, listen to the carotids. Okay, ASMR, not quite sure which one is which. I cannot hear that in the carotids. Probably more of an MR murmur, but if I can hear that murmur in the carotids, probably more aortic stenosis. Does that help to answer that, Christian? Good. Investigations, obviously, you're going back to investigations, do your basics. X-ray, any valve problems, definitely get an echocardiogram. All right, anyone who comes in with chest pain, you think the patient's got aortic stenosis or they've got, chest pain and they've already even had cabbage, you definitely do want to go and have a look with a coronary angiogram as well. Management, always breaking down to conservative, medical, and surgical. Medical and surgical obviously depends on what conditions there are. So I will always read up about things like your valves, know what the indications for surgery are for TAVI, so aortic stenosis, mitral regurg, aortic regurg, mitral stenosis. Know your surgical indications well in these patients. Infective endocarditis, there are 5 indications for surgery. Know them, all right? Memorize them, all right? And take note of it when you go and see your infective endocarditis patients when you're on the ward, all right? Know your indication for a cabbage. Know your indication for maybe more of a PCI approach instead. Conservative, is not exhaustive, all right? Always say that you will undertake an MDT for any patient, cardiac or non-cardiac, you will undertake an MDT approach for the patient, all right? Conservative, okay, say you've got a patient with heart failure or with secondary to an MR, all right? You know your medical, you know your surgical indications, but they also have heart failure because their LV is down. You want to get the heart failure nurses involved, okay? You want to go and get cardiac rehab for that patient with who's had a cabbage, all right? Lifestyle modifications, fluid and salt restrictions in our patients. Tell them to stop smoking. Driving restrictions, know your DVLA indication for which sort of patients need to stop driving following the procedure. Before I move on to three short cases. 5 indications for TAVI. No, there are not 5 indications for TAVI. I said 5 indications for infective endocarditis. But if I say TAVI, I do apologize. Right, case 1. Sorry, any other questions before I move on to cases for the last 10 minutes? So this is where I'm going to get you guys to do the work now. No, nothing. Okay, good. So 75-year-old man with chest pain, perform a cardiovascular examination. Right, 75-year-old man with chest pain. You guys will probably have done a lot of take by now. Start thinking about what differentials that you have for a 75-year-old man with chest pain. Okay? He's comfortable, his hands and nails, everything is normal so far, and he's got a normal chest. All right? There are no scars. All right? No extra lines, no pacemakers, no heaves or thrills, but all you can hear, oh, I really hope this will come up. So I will share screen.
those heart sounds, you'll hear a systolic murmur.
I've just dropped the link.
Other signs that you'll find in a patient with aortic stenosis,
Right, can anyone hear that? Can anyone hear that thing? So I've dropped the link. Nobody could hear. So just go to I'm gonna give you the answer, okay? Just go to minute 14 of that link and just sort of familiarize yourself with an aortic stenosis murmur, okay? So click on that link in the chat. Can't see the link either. Here? To host and panelists, that's why. Everyone, there we go. Sorry, guys. There we go. Go to minute 14. Familiarize yourself with an aortic stenosis murmur. So go to minute 14. Okay. Well, actually, minute minute 14. So at 14 minute 18 onwards. Are we okay with that? So this is to everyone. Perfect. Good. So the patient does not have edema. So you have an aortic stenosis diagnosis, all right? I'm going to give you the answer here. Now, question, what are the causes, most common causes of aortic stenosis? So I want you guys to drop it in the chat. Yep, degenerative, that's the most common one. Yep, degenerative calcification. Another one. So you tend to see in younger patients. So, patients in their 50s, patients in their 60s, all right? Bicuspid aortic valve, all right? They can be quite unwell, okay? They will be really, someone who's disproportionately short of breath. Yeah, rheumatic fever, you can throw it in there as well. Tends to be another textbook answer, but they tend to cause more mitral. All right. Endocarditis. Endocarditis tends to cause regurgitation because it will cause your valve to flail rather than rather than causing a stenosis. So I probably wouldn't put endocarditis in my differential. You want one where it will degenerate and cause calcification, which endocarditis doesn't tend to do. Okay. So yeah, so I'll stick with 3. So rheumatic fever last, but in a 70-year-old man will tend to be degenerative calcification of your trileaflet valves, and then you go for your bicuspid. That doesn't mean that your older patients cannot have bicuspid, but patients with bicuspid tends to manifest earlier in age. Paget's, don't think I've seen one before. That's something that I'm not sure. I'm sorry about I'm not sure what the relation between Paget's and aortic stenosis is. Okay. Now, in someone with aortic stenosis, and particularly bicuspid, what other what other diseases you want to look out for? If the valve is affected, aortic disease, exactly. Always look, yep, Turner's, okay, yeah, if they're syndromic with their bicuspid, yep, aortic disease. Patients with bicuspid aortic valve have got a higher risk of developing aortic aneurysms. So definitely want to look out for and take note if the say this is your cardiac history exam, and these sort of patients you want to look out. If they complain of chest pain radiating to the back, always look for aortic disease as well. Good. Other conditions that may be associated with aortic valve diseases, particularly in a 70-year-old man with chest pain, what are the conditions you want to think about in your differentials? Yeah, ischemic heart disease, exactly. All right, common is common. Patients who are older have got a higher risk of developing ischemic heart disease. All right, patients with aortic stenosis, there is a likelihood that they will have coronary artery disease as well. Okay, they can go hand in hand, so always make sure that you have that in your differential diagnosis. All right, good. You also then want to look for things like heart failure, all right, in these sort of patients. Okay, so what's the character of that murmur for aortic stenosis? Okay, ESM, yes. All right. What else apart from ejection systolic murmur? Say, you've got a murmur that is loud and you can hear in, all the four regions. All right. What can help you to differentiate? Okay, that is more of an aortic stenosis rather than a mitral regurg murmur. Yeah, radius to carotis increases on expiration. Slow volume pulse. Yep, very good. Okay. Anything else that points you more towards a severe aortic stenosis? Okay, what are the cardinal features? You got slow volume pulse, which is good. Narrow pulse pressure, quiet S2, exactly. Soft or absent S2 will point you more towards an aortic stenosis rather than, say, a mitral regurg or an aortic regurg murmur. There we go. Features of severe aortic stenosis. You may feel a palpable thrill as well. So standard stuff, get your OPS, get your ECGs, okay? Ask for bloods, all right? And then get an echocardiogram, get an angiogram as well, all right? We'll talk about, always just think about what sort of patients you want to, obviously in this sort of patient, say you're on take and then you clock this patient in, you've got severe aortic stenosis, you work them up. Okay, always mention that you're going to get a cardiology involved because you're not going to be the one who's dealing with this. All right. And then depending on their level of frailty, they'll see and their coronary artery anatomy, you want to decide, are they a TAVI or are they a CABG candidate? All right. And then you then want to think about, if they've had their surgery or if they've had their TAVI, how are you going to monitor them? Okay. Because you're not going to discharge these sort of patients from clinic. Okay. You're going to hook them onto yearly surveillance. All right. Are we happy with aortic stenosis so far, or do you have any questions? Oh, GDMT. If they've got heart failure, guideline directed medical therapy. So sorry, I was just being lazy with my um with my typing there. Any other questions with aortic stenosis? Nope. Good. Right. These two will be shorter. Short of breath, examine her cardiovascular system. Great. I'm just going to do this and put it in the chat. Okay, so do listen to that. All right. She's got pitting edema, pulse is irregular, JVP is raised, bedside, they'll be uncomfortable. Well, they're comfortable, they've got a spray. All right. And then you can hear this. Have a listen. Just familiarize yourself because this is what came up for my exam. All right. Just familiarize yourself with that murmur. And just close your eyes and listen. Can you sort of different compared to the previous one? Okay. Are you able to differentiate the sort of slight difference between a prosthetic, okay, a bioprosthetic valve against a metallic valve? Okay. You have, I think, Rushi, I think you have, it's really tricky. I agree with you. It's better when it's really quiet and not with me shouting over the screen, but with headphones on. So, any questions before we move on in terms of the difference between bioprosthetic and also a metallic? Were you asked to distinguish? Yes. Okay. Yes, because you need to know whether it's a bioprosthetic valve or whether it's a metallic valve. Okay. Metallic valves, most of the time, you can hear it at the end of the bed. All right. I've had I think with my patient, I had someone who's had a cabbage. I think they've also had a valve replacement at the same time. What you need to know is the type of the valve, which valve was fixed. Was it, and then that would depend on which valve you can hear the click. Is it at the mitral, so S1, or is it the aortic valve that was changed at S2? All right. So it's not easy, and certainly it does take some time when you go onto the ward to go and find someone or go to the cardiology valve clinic to go and listen to a bunch of metallic valves, to go and listen to a bunch of prosthetic valves, so that you develop that knowledge of how to differentiate between the two. For me, what works is that if you can hear at the end of the bed, is going to be a metallic valve compared to a bioprosthetic. All right. And obviously you look for things like, have they got bruises? Because patients are these patients with metallic valves will all be on warfarin. So they'll all have a lot of blood tests. They will have bruises. As in, can you distinguish between normal valves and prosthetic? Yes, it will be the click. It will be the click of the valve. it will sound different compared to a normal valve. Because if you think about it, your heart is having to pass through stent, the frame of the stent, and also and also the valve itself, which is different than than a than a human valve. It will sound different. But yeah, there's a lot more things is going through the stent frame, the ring, the prosthetic ring that keeps the valve in place. All right, and that's why you get the added sounds. Is that okay, Neve? And is this TAVI or a tissue valve? Well, what I've sent in that link was a prosthetic mitral, but it wouldn't be a TAVI, no. But TAVI valves are tissue valves. They're not metallic. Happy with that? Cool. Good. So yeah, same as before. All right. Don't know why I put metallic there. It definitely sounds more prosthetic than metallic. So do the bedside stuff. OBS, ECG, get echocardiograms, get all your bloods done. Anyone with valve disease, always look for things like, are their valves working? Okay. If they've come in with heart failure and they've got a valve, I'll be very worried, because you want to know, do they have an infection? Okay, like infective endocarditis of their valve, or what's even worse is that valve working or not? If that valve has got a stenosis or it's just flailing because it's not working anymore, so you might get a regurgitant valve instead. Obviously, look for, you want to talk about medical and surgical management. If they've got valve failures, you want to offload them, fluid restrict, daily weights and UNEs, and a cardiology review. Make sure that they're warfarin INR range. Okay. Last but not least, 50-year-old man comes in with dizziness, examine his cardiovascular system. What disease is this? What disease is this? The last one. Yes, perfect. Myotonic dystrophy. Very good. It is myotonic dystrophy. Myotonic dystrophy, you are at increased risk of developing heart block. And why do you think this is more myotonic dystrophy rather than, yeah, what are the cardinal sort of facial features of someone with myotonic dystrophy? What are the facial features? Yeah, baldness is correct. Anything else? Ptosis, okay. What else? How about the shape of the face? Yeah, it has a long sort of haggard sort of look, okay, with the face. It looks very long, elongated. Okay, good. So that's myotonic dystrophy. I think we've had it somewhere about Noonan's. Went to an ACHD talk the other day. I'll just show you what Noonan looks like. Da, da, da. Yeah, maybe not that. Images of Noonan. There we go. Right, so this is more of a new. Let me just share. Where is the share screen? Bum, bum. Right, that is Noonan syndrome. Okay, it's not that elongated. I agree, maybe some pattern balding as well, but these patients tend to carry a more like happy look and stuff compared to your myotonic dystrophy. Noonan syndrome doesn't increase your, they have, obviously, they tend to have more a sort of AVSDs, VSDs, okay? Issues as well, issues with their pulmonary valve actually with Noonan syndrome. All right, rather than AV blocks. Yeah, slanting eyes, low set ears. Okay. Pulmonary valve involvement rather than heart block. Okay, that's with Noonan syndrome. All right, good. Are we happy with things so far? And I think, oh yes, if they've got a pacemaker, always remember to mention that you want to interrogate the pacemaker. They don't, and this is for real life in general. You don't need to a 24-hour take if they have a pacemaker because you can just interrogate it. Good. And this comes to the this brings us to the end of the talk. Does anybody have any questions before we finish? I do apologize for the I yeah, just don't know why the videos don't project well on these streaming platforms, but the talks will be on YouTube. But if you want the PowerPoint, I'm more than happy to send it to you as well, or send it via Shuaib. Any questions? Any burning cardiology questions? Any sort of any patients in particular that you've sort of practiced on that you're like not quite sure what's listening? I couldn't get the difference. What difference between valves, biovalve? Okay, so bioprosthetic versus metallic. Okay. So metallic valves, if you've heard enough, okay, you will hear it at the end of the bed, even without putting a stethoscope on the patient. All right? You will, it's very easy to find. You hear a click at the end of the bed, that is definitely a metallic valve. All right? You cannot hear a bioprosthetic valve at the end of the bed. That's one indication. Number two, metallic valves, these patients will be on warfarin, all right? Nothing else, they will be on warfarin. So look for all the bruises from where they've had bloods taken, all right? Yeah, exactly, like ticking off the clock. You hear a metallic valve, that's 50% of your job done. Will there be a sternotomy scar and bioprosthetic? Yes, some will have surgical tissue valve replacements, okay, especially if they tend to be on the older side. But just be careful. TAVI valves are bioprosthetic. All right. TAVI valves are bioprosthetic, so there won't be a sternotomy scar. All right. You're going to look for maybe scars in subclavian, apical, femoral. All right. So I wouldn't just hedge my bet on that sternotomy scar and, that's definitely metallic. That's definitely bioprosthetic. Always just think, okay, is there a bioprosthetic? Is there like a metallic click? If that's not, but you still hear a click, it's more likely to be a prosthetic one. Both S1 and S2. How do we identify bilateral valve replacements? I'm not sure they'll find. Oh, no, that's tricky. I mean, yes, you will hear both clicks in the you'll hear clicks in S1 and S2. All right. If they're mean enough to ask for someone who's had two valve replacements, I think that's a bit mean. They tend to only pick one. All right. Someone who's just had one valve replaced. All right. Also, if there is, wow, okay, you had that in your exam. How do we identify bilateral valve replacements? Do they both do they have like one metallic, one bioprosthetic, or both of them are one or the other? Harsh systolic murmur, are we so if there's a harsh systolic, are we able to find out mitral valve replacement? Harsh systolic murmur, we find out mitral valve replacement. I mean, these when you have a valve replacement that's harsh, you got to think, okay, is this valve you know, starting to get stenosed. Okay, if there's a systolic murmur there, all right. Normally you tend to just hear a click, but if they start to sound like things like mitral regurg, or if your aortic replacement is starting to get stenosed and starts to sound like aortic stenosis, I will be worried. So yeah, clearly metallic, but ask if it was both S1 and S2. Ask if it was both S1 and S2. If they've only had one valve replaced, you shouldn't have both S1 and S2 unless they really trying to be tricky and have both aortic and mitral valve replaced. Personally, I don't think I've seen anyone, even at the QE, that have had both valves replaced. I think that makes things quite difficult because the INR ranges and stuff. I don't think there is anyone that I've seen in the past that have had both valves replaced. So it would tend to be one or the other. Any other questions? If there are no questions, I will send the PowerPoint to Shuaib um, so that he can distribute it to you. Otherwise, the rest, if you want to watch a video, it will be on the YouTube channel. All right, good. I think let's end it right there. I'm 20 minutes beyond time, so I do apologize.
Thanks a lot, Chern. That was brilliant. I think people really found that beneficial. And just on the last point about the double valves, it does come up rarely, and we do have a patient with that on the course if people are interested. So that's my final plug for the course, and I'll leave everyone to enjoy their afternoons. But yeah, thanks a lot, Chen. I think everyone's saying
Yeah.
thank you. They really
Wait,
enjoyed.
I'll attend that one as well if you manage to find someone with a double valve replacement.
She's come on pretty much every course, I think. So I just think you've been in a different room. But yeah, I'll get you to come and listen. Actually, it'll be good to
Oh,
have
wait.
an
Bloody
expert
hell.
opinion.
Wow, okay, that's fantastic.
But cool, guys. Yeah, we'll see you later. Join the WhatsApp group, and we'll keep you up to date with the webinars and things. But yeah, take it easy, and thanks, Chen.
Bye.